And so now I'm going to let Dr. Mandayam come up and talk about how his perception of how patients can really help your providers take better care of you.
Can you all hear me? Okay, perfect. This is probably the only ballroom in the world where you can say, does somebody have Zofran, and half the room raises their hand. How about prednisone? How many people have prednisone? Look at all the nephrologists in this room. We should hang our head in shame. So many people still on prednisone, right? That's terrible. I'm Sreedhar Mandayam. I'm a nephrologist. I live and work in Houston. There are several of my patients in this room and my clinical trial patients in this room. So they're all making sure that I stay honest and don't BS. So you can call me out if I'm saying something I shouldn't be saying. And Kelly said that there are people here that spend all their daytime thinking about protein-spilling kidney disease. I'm definitely not one of them. I'm mostly thinking about, is it my turn to pick up my kids and take them to the swim lessons or something like that. But I do take care of patients with kidney disease and protein-spilling kidney disease. And it's wonderful to be here to talk to all of you. I think the only thing I want you to take home from my talk is that if you're not happy, raise your hand and ask for an explanation. You're well within your rights to say, I don't agree with this, or I'm not happy with this, let's try something different. The other thing is, of the 200 people that are experts in protein-spilling diseases, I think about 10 of them are here. So that's about 20% of the entire expertise in this. So catch them, show them your biopsy, show them your urine protein, make them give you an opinion. As long as you promise not to sue them, I'm sure they'll be happy to tell you what to do next. Okay, next slide, please. So a lot of what I'm going to say here is truthful, maybe slightly controversial, so I'm going to have my colleagues push back if I am BSing again. So I am actually an academic nephrologist. So I work at a university, and I'm fairly protected. I have lots of time to do pontificate great things. But this is sort of my typical day. So I have to catch. So nephrologists make money seeing dialysis patients. That's our bread and butter. There's no secret here, right? And dialysis units across the country typically run in 3 shifts. There's first shift, second shift, and third shift. So as a nephrologist, if I'm a successful nephrologist, will have patients in all of the shifts that I'm taking care of. So I have to get up, get to my dialysis unit to catch first shift, which is rolling out probably by around 7:30. Once I finish seeing them, talking to them, explaining labs, et cetera, then I have to get to my hospital to go see my inpatients. I usually have about somewhere between 15, maybe 25 inpatients that I have to see for the next couple of hours. And then after that, second shift needs to be seen. So I have to drive, go see another 10, 15 people on dialysis, come back to my clinic, and then see patients in my CKD clinic, maybe twice a week, sometimes 3 times a week. And then when I finish, I have to go back and see third shift, because third shift got on somewhere around 2:30, 2:45, and ends around 6:30, 7 o'clock. So once that's done, I guess somewhere in between, I have to eat lunch, pick up my kids and take them to their various activities, and then go back, have dinner, and then sit down and write notes. So my day begins sometime around 7:30 in the morning, and if I'm lucky, it ends at around 10. And we have a bunch of docs in this room. Do you all disagree? Is this atypical? Anybody would, right? So this is, and also I'm probably a lot more protected than some of the private docs, because the private practice docs are probably running around to multiple units to see patients. It's not just, I just have one unit because I work at a university, so I'm very lucky I can do this. And in between all of this, I somehow find time to squeeze my clinical trial patients and take care of them. So this is a typical day in the life of your nephrologist. So have some sympathy, some pity. When I get to see some of you in clinic, and I have seen some of you in clinic, in my 20-minute encounter, so the CMS, which is Medicare, says that if I see somebody for follow-up in clinic, I'm on average supposed to get about 20 minutes with them, because that's how much they'll pay me for. And typically an afternoon clinic for 4 hours, 3 hours has about 4 or maybe 4 new patients and about 8 to 10 follow-ups. That's sort of an average clinic. Some people are more, some people are less. So you get 20 minutes of my time, or I get 20 minutes of your time, depending on how you look at this. And in those 20 minutes, these are the 6 things that I am expected to address in my clinic visit. How bad are your kidneys? What is your stage of kidney disease? Do you have protein in your urine, and am I doing something about it? Are you anemic, and are we doing something about it? Do you have bone disorder? Is your PTH okay? What's your vitamin D levels? Do you need a transplant referral? Should I get you a fistula or a PD catheter? And all of this is in 20 minutes. So if the first few minutes are opening your chart and trying to figure out why you're here to see me, and then, hello, how are you? What have you been doing the last few months? And I still have to finish writing my notes for you in 20 minutes. So what are the chances that you and I are going to have a meaningful conversation on what is the latest and greatest in FSGS or IgA nephropathy or membranous nephropathy or whatever it is that is afflicting you today? Okay? So if you're lucky, you might get 3 minutes of my attention for this specific problem. And if you're not, it's probably not even going to feature prominently by the time we finish talking. I'm not making excuses, right? I mean, let's be clear here. I think you all deserve better care. Every doctor in this room agrees. But these are some of the realities of what's happening from my side that you need to be aware of and therefore construct your encounter. Again, do you really think that you have enough time, or your doctors have enough time to actually have expertise in rare kidney disease? Majority of us know very little about rare kidney disease. How many people in this room, when they had a biopsy or their kid had a biopsy of FSGS, had this doctor look at them with horror saying, oh my God, I have no idea what's happening here? There you go. Many have realized it. Many have, maybe have PTSD and forgotten that look on their doctor's face. But it is true. Majority of our clinical practice is diabetes and hypertension. Were I not doing clinical trials, which I spend a lot of time doing, I would have very little knowledge or expertise on IgA, on FSGS, on Alport syndrome, or any of these other diseases that I do clinical trials in. My nephrology fellowship training was mostly about how to take care of dialysis patients, get them to a transplant list, and follow them after transplant. Or what if you get sick in the hospital and develop something called acute kidney injury, end up in the ICU, then how do I manage you? We're very good at doing those things. We're not really good at managing tip lesion FSGS or collapsing FSGS or IgA vasculitis or any of these other things. I get lots of journals. My God, my journal stack is this big. It goes straight to recycle. I don't have time. If I'm driving from 7:30 to 10, when am I going to read? Maybe podcasts, maybe I listen a little bit when I'm driving. I actually learn a lot when I go to the drug company dinners, and it's something that everybody discourages. It's frowned upon. People think it's terrible for your doctor to attend a drug company dinner. There's actually a federal website where they post how many dinners your doctor attended to. If docs stop attending these dinners, good luck. Nobody's going to know anything on what's happening in the latest and greatest and the newest things in medicine. Yes, they're biased. The drug company is selling their drug, but the docs are actually not idiots. They're going to sit and understand what is being said, appreciate it, make their own determination. We all know that the science is progressing, right? There's now ChatGPT-5 and there's AI and people are launching rockets. So I know that there are great things happening in kidney disease, but I would not have known what those great things are. I would not have known that somebody is launching a trial on an anti-SUPAR antibody specifically for FSGS. I would not have known that there is a trial for factor D blocking in patients with IgA nephropathy, or that somebody is blocking CD38 for patients with membranous nephropathy. These are things that they don't teach you in fellowship. They don't, unless you're keeping up to date, unless you're actually participating in the trials, you probably won't even realize this. The majority of your doctors probably do not know what is happening in the front lines of kidney disease treatment. We're not homogeneous. The problem, and I'm going to highlight this in a few more slides, most clinical trials in America are full of white Caucasian patients in the ages of somewhere between 20 to 40. Most patients I see in my clinic are not at all white Caucasian patients in the ages of 20 and 40. So the racial composition of the people in this room, the racial composition of the people that come see me in clinic that suffer from all these diseases is very, 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 very different from the racial composition of the people that actually participate in clinical trials. So kidney disease does not discriminate. It is as common among white, African American, Asian, Hispanic, all kinds of people. But our treatments are mostly derived from trials that are done on young white men and women. So we don't really know very well that do these work in tiny Vietnamese ladies that are sitting in front of me in clinic, or the big African American basketball player that is here sitting in front of me in clinic. So kidney disease, again, and my exhortation to all of you is that you probably should be thinking about participating in a trial. You probably should be thinking about getting your genetics tested, okay? When it became possible to sequence DNA and get genetic information, there was a lot of controversy on will we get discriminated against based on genetic information? Will insurance companies do this, do that? I think it's all overblown, right? If you know what is wrong with you from whatever reason, then eventually, sooner or later, a treatment or trial, something will come up that you can be specifically targeted and help you. The greatest example for genetic testing is APOL1 kidney disease. So for years, we knew that African Americans had a higher risk of FSGS. And then over the years, they have now discovered that African Americans that are homozygous, that means they have two bad copies of a specific gene called the APOL1 gene, end up developing FSGS. Now that that information is available, a pharmaceutical company called Vertex has launched a trial that is now in phase 3. That means in probably a year, that drug will be out and can be used on patients. So African American or anybody that has the APOL1 gene and has FSGS will have a treatment. And the reason that happens is because lots of people got tested and they identified that this gene was a problem. So, we should definitely, right here is the KDIGO guideline for IgA nephropathy, and in the center, right in the middle, says consider enrollment for a clinical trial. How many people in this room are in a clinical trial? I'm happy to see. How many people have a rare kidney disease or have a family member with it? Why aren't you all in clinical trials? Does your doctor know what to do for you? There you go. Okay. I think I can finish. I don't have much to say after this. So here are the trials, which all of you that have FSGS, people that have Alports, these are all the list, people that have IgA nephropathy. If you have a disease for which there is no good cure right now, get yourself on a trial. You will get to see doctors like some of the people here in this room that will see you every week, every month, follow closely, run tests on you. I tell all of my clinical trial patients, I am not your kidney doctor. You have your own kidney doctor, but I'm a second set of eyes. I'm here to make sure that your kidney doctor doesn't do something that will hurt you. I'm here to make sure that whatever we give you makes you get better. Why were only 3 people in this room on a trial? Have your doctors asked you to participate? No? I work at a cancer center, MD Anderson, okay? It's one of the best in the country, maybe the world. Every patient of mine is on a clinical trial. If you are unfortunate enough to develop cancer or have a family member that develops cancer and comes to MD Anderson, you're automatically enrolled in a trial. We have not cured cancer. I know we're trying hard to, but the philosophy is that every patient gives us information that we can learn, that we can then use for the next one to develop better treatments. And that's why we have such wonderful drugs, immunotherapy and other things for cancer. But for nephrology, other than prednisone, tacrolimus, cyclophosphamide, Acthar, we haven't made any progress. And now we have Tarpeyo and sparsentan and a couple of other things. So unless all of you go around and start participating in clinical trials, there will certainly be no incentive for the pharmaceutical industry to invest hundreds of millions of dollars to bring a new drug to market. The only reason, can I go back? How do I go back? Okay, so on the left, or my left, is it your left? Okay, on the left are a whole list of trials going on for a disease called IgA nephropathy. The only reason pharmaceutical industry has invested so much money in IgA nephropathy is not because it is a very, very common disease. It is because they went to the FDA, and the FDA approved a change in a surrogate marker, which is reduction in protein. So the FDA allowed companies to bring a drug to market, not because it stopped somebody from dialysis, not because it cured IgA nephropathy, but because if they lowered the protein levels in the urine, that was good enough for approval. And as soon as that happened, look at all the companies that are trying to cure you of IgA nephropathy. Similarly, if all patients with FSGS, if all patients with Alports, with membranous, if we could get registries, if we could get the community involved, we should have hundreds of companies putting up trials so that they can go out and make a fortune or whatever it is, but I can take care of you. One of the big problems is when I was in training, we didn't really know how to enroll patients in clinical trials. So if your doctor has never sent somebody to a clinical trial, they have no idea what to do. Okay? And they're mostly afraid that you might leave them and go after that doctor, the trial doctor. I'm very successful in holding on to my trials because I tell them I'm not your doctor. You go back to your doctor. So they go back and report to their nephrologist. They take their labs and say, I started the study with Dr. Mandayam, and look how well I'm doing. And the doctor gets credit, right? So it's important that if your doctor does not know how to enroll somebody for a clinical trial, maybe that's the barrier. And if that's the case, then you can help them. Barriers, right? So if something is not happening, it's probably because there are certain barriers. So there's provider barriers, there's patient barriers. People are afraid. People are scared that something terrible will happen if they get on a trial. And when I ask people, and maybe I've been doing this for over 10 years, I've hardly ever had anybody say no. Because I think doctors rarely ask their patients or their families, do you want to participate? I think it all sort of framing matters. If you say, I'm going to do an experiment on your son or daughter with a new medicine, hell no, I'm not going to sign up for that. But if we say this drug is safe and has been tested in 1,000 people and is now in phase 3 and we're going to see how much it will help your child, sign me up. Everybody's going to say yes. Some people refuse to participate, and that's okay. But I think majority of our participants have never been asked before. In general clinical trial practice, you see that 80% of trial participants are Caucasian. At my site in Houston, we have about 40 to 50% are African American, 30% that are Asian, and only 10% that are Caucasian. That may just be Houston's demographics, but we are certainly proud of the fact that we can invite any of you into our site and have you participate in a trial. There is no barrier there for us. I think this is my last slide. So what I want you all to take away from this is be your own advocate. I mean, you have one body. You have to take care of yourself. Nobody else will be. And also, for sure, don't assume that your doctor knows everything that they should know. They probably know more than you do about your disease, but there are many diseases where you probably know more than they do. And a lot of times we're using the same sources of information. We're probably all looking up Google or Bing or whatever. I can maybe do a better search than you do because I know which sources to trust and how to parse through material fast enough so I can say this is good and this is not. Number 3 is very, 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 very important. And I tell all of my patients to do this. Never go to a doctor's appointment by yourself. I go with my wife to all her appointments because I know that she's not going to ask the right questions, or I know that she's nervous, or she'll forget, or that she's overwhelmed by the doc or the procedure or whatever that's happening. So please have somebody with you. Please take notes. Please ask questions. 20 minutes is my problem, not your problem. For those 20 minutes, you have the full attention of your doctor, and you deserve answers to all of your questions. Use all the resources, Google, search, whatever you want to do, right? And go prepared before you go into your doctor's appointment. And your care team, and that's not just the doctor, the nurse, the MA, the NP, whoever it is, they should meet you as an equal partner. This is your journey. They're there to help you. And if they do not, then have the courage to get up and go find somebody else that cares about you. And this is it. Questions? Are we doing questions afterwards?
Yeah. This is just a last slide.
Good.
We can just run through this together,
Okay.
and then we'll do questions. This is just
Kind of to wrap it up, and as an overview of what we've talked about this morning, just this evolution and this thought of a modern patient-provider relationship. We talked about what's innovative and outdated. So outdated is asymmetrical, one-sided conversations with your doctor. Innovated is a balanced, collaborative relationship. Outdated is this assumption that the doctor is always the expert and makes all the medical decisions. Yes, our physicians are very smart and have invested a lot of time in their patients, but they also need our help, especially in rare disease. So the innovative modern approach would be that the patient and doctors are both experts and make decisions together. This idea that the doctor brings all the available treatments to the table is outdated, as you heard, because they don't have time to learn everything all the time for every diagnosis. And so it's up to us as patients to know what our options are and ask our physicians, hey, what about this new therapy? What about a clinical trial? And then we can't expect our doctors any longer to be up to date on all things. They have to make money, they have to provide for their families, and there's only 24 hours in a day, and they're already working from 7 a.m. to 10 p.m., and that's really not fair to then go expect them to know everything about all things. And so hopefully your doctor also respects your knowledge and your experiences and your wants and needs and applies that to your relationship. So. And we can take questions now. I think we have some mics at the back. Maybe if I could get a couple of staff to grab a couple mics and run them around to folks who have questions. Yes, Julie, you can speak loud enough.
they talk about clinical trials and that the RTO goes involved with clinical trials, but the problem that I've encountered is still the parameter.
Yeah. 100%.
Yeah.
100%.
Unfair question, but okay, I agree.
Oh, sorry.
So-
Can I have you repeat that really quick? Because we're recording this, so if I could just have you repeat that.
We talk about clinical trials, and when we go to talk about clinical trials with our doctors, we don't fall into the parameters. So how can we get into these clinical trials if we don't fall into the parameters?
So a brief history lesson will be helpful. When pharmaceutical companies launch trials, they typically don't want to take a lot of risks, so they try to narrow it down to this ideal human being that will be positive in the trial, that makes the trial succeed, and therefore gets their drug to market. That's usually for the first drug. So now I showed you the slide with 14 IgA nephropathy trials. The bottom 8 IgA nephropathy trials, they're willing to take anybody, because the first drug is already in the market and has such a narrow prescription range that there's a whole host of patients that cannot get the drug because the FDA said you didn't test them on these people. So now all of my IgA trials have people with eGFR greater than 20, urine protein less than up to 700 milligrams. When I first did the IgA trials, you had to have an eGFR greater than 90, and you had to have 3 grams of protein. So yes, there are some boundaries, but the boundaries are elastic and they actually get bigger as more of us participate in trials, because then the company knows that there are all these people that we said no to like idiots that had this disease that we could have sold the drug to. So somebody has to take the first steps. So as more people start signing up, trials become wider and more inclusive. So yes, there are inclusion-exclusion criteria, but they're getting more and more liberals, and it has to start.
Rebecca?
So my name is Rebecca, and my son has nephrotic syndrome, and his father is African American, and so every time they do a CMP, they never show the glomerular filtration rate, and so I've heard that that is an important part.
They never show the glomerular.
It says like on his test, it'll say African Americans or more, and they just don't show it.
So previously, the GFR that they show in a CMP or a BMP is an estimation. It's not an actually measured GFR. So there was something called the CKD-EP cohort. So they took 10,000 people across the country and did a spot blood test and a 24-hour measurement of GFR and came up with an equation that correlates for this spot blood test result. Previously, they used to split it into African American and non-African American. So there would be these eGFR for African American and eGFR for non-African American. And that would give people with African American identified race a higher eGFR for the same creatinine. So what that led to was that a lot of African American patients became ineligible to be on the transplant list because they had a higher eGFR for the same creatinine. And so as a consequence of that, the National Kidney Foundations and the American Society of Nephrology eliminated the race correction because they wanted everybody to be equally able to get a kidney transplant. So therefore, the race is eliminated now in eGFR. But it should still show an eGFR. If it goes to a CLIA certified lab, they have to
Maybe after I can
afterwards show me your results.
It does not show, and I've asked specifically, and that is what I was told.
I'm not a pediatrician, so I don't know. Do pediatric BMPs show eGFR? I have no idea.
They should. They should. Yeah, they don't. No, they
Okay. So again, because the CKD-EP equation was validated in adults and not in children, so therefore that representation of the 1:1 correlation between creatinine level and eGFR percentage or number is not that accurate for kids because the study was done in adults.
Well, my son did have like the protein to creatinine ratio testing done, before he was diagnosed. But after he was diagnosed, his nephrologist said that it would be pointless. It will always be high.
How does he know that your son is getting better then?
I'm sorry?
doesn't think your son is getting better.
Exactly. He also doesn't test his mycophenolate levels ever.
Mycophenolic acid levels are controversial. Most people don't test them, but they have to be testing protein in the urine somehow, either 24-hour or spot.
I test at
Well,
home.
yeah, we'll connect you with a pediatric nephrologist and get to the bottom of it.
Well,
Yeah.
Yes, thank you.
Sounds great.
Thank you. Any other question? Dan?
We have a bunch of
Rebecca,
people,
or
hands up.
Dan?
Sorry.
Oh, sorry.
I don't need a microphone. Anyway,
Dan got
Hi.
the front seat. So he
thank you.
gets the
Front
question.
seat, yes. So my question about the clinical trials, it seems like per your slide that they're pretty open right now. How are these pharmaceutical companies tackling the geographical location? My experience is that it's hard to get access to the clinical trials if you don't live in that particular city or region. So if I'm across the country and somewhere else around the country, how do I get access to these widely open clinical trials? Are they doing this virtually? Do they have access to other clinical places that are around the country, those kind of things?
Yeah, great question. So the FDA has, over the last few years, mandated that we need to make our clinical trials as easy for our patients as can be, while maintaining the scientific integrity, et cetera, et cetera. So a lot of clinical trials have virtual visits where many things can be done virtually. Some things you have to actually go to the site if there is a blood draw for a PK measurement and other things like that. Second question, if you don't live near a clinical trial site, majority of clinical trials will actually pay for your flight and hotel to come for the visit and go back. My clinical trial site is open on Saturdays and Sundays. I actually am going to go probably tomorrow or day after, see some patients that can only come in on the weekend because they work during the week. So sponsors now understand that this is an issue, and they're willing to support patients and the trial sites to be open after traditional hours on weekends and to make it as easy as possible. So I have patients that regularly fly in from Oklahoma City to come and do clinical trials in Houston. It's an hour and a half flight, and they spend the night close to our site, go to Galveston, enjoy themselves, and then go back home.
Thank you.
I think we had some, yes, right here, Lauren.
Thank you for being here. Aside from the lab tests, aside from the lab tests that we all undergo at each appointment, what's the one piece of information that you need from us that will help you with our visits?
Depends on what is wrong with you, I guess. I would probably, the most useful piece of information is are my treatments helping you? Right? And it could be, I feel better, I feel the same. It could be my son's urine protein is coming down. It could be that, I read about something that may be better for me. I'm not going to unleash a bunch of all of you on Google coming up with, I like this thing and that thing, but I think you should be informed. I think you should be empowered. I think your doctor certainly does not know everything that he or she should know. So if you come up with some crackpot idea to cure your disease, I think you deserve a conversation, right? And he or she should tell you why this is not the best because there is no evidence, or the person saying this is a loony or something. They owe it to you to tell you why they don't think this is a great idea. And if they don't have a good answer, maybe it is a good idea, right? And as I tell all of my patients, whatever you do, come back in 3 months, I'm going to check your labs and we'll see if it worked.
I think Lisa Semino Birdie.
What are your thoughts on the new cystatin kidney function test?
Cystatin, it's a pretty good, I use it quite a lot because my patients have, most of my day job patients have cancer, and so they lose a lot of muscle mass, so the creatinine-based eGFR equations are very inaccurate. They're usually artificially low. So I find cystatin C-based eGFR is a slightly better representation of your level of kidney function than creatinine-based eGFR. I mean, it's mostly useful if you want to precisely know how good your kidneys are, which we rarely do. As long as we're in the range of 30%, 60%, we're okay.
Back in the back.
So I actually used to be a patient of yours years ago, and I now see Dr. Raghavan and Dr. Murthy. And recently, the IgA has reoccurred in the transplanted kidney. And so one nephrologist says that I should just wait and look at the results, and one wants me to start Filspari. So I was kind of wanting to know what direction I should go with that.
So because your kidney transplant doesn't cure you of IgA, the IgA will come back in your new kidney. Because you're immunosuppressed from the transplant, it may not be as severe as it was in the original kidney. So I think the answer to your question is it depends. If you have a lot of proteinuria, then for sure Filspari. If the proteinuria is less than 500 milligrams, then maybe not.
Any other questions? One right up here. You can just shout.
All right. Is there any clinical trials for people on dialysis that have that FSGS?
Okay. Let me repeat the question. The question was, are there any clinical trials for people on dialysis with FSGS?
If you're already on dialysis, I don't think so. Most of them are looking for people with GFR of 30 or above. Some of them are allowing up to 20. Yes, sir.
Actually, I Paul, the kid is
Yeah, sure. Actually, I had a follow-up question to his. So if you have FSGS and you have received a transplant, but you're seeing signs of relapse, would that also disqualify you, or that would you be eligible for those?
Some trials will let you, but some will not. So it's trial specific.
Okay.
And I do just want to mention while we're running a mic over to the back here, we do have a breakout session around clinical trials. So those of you who have lots of questions about clinical trials, I highly recommend joining that breakout session in a couple of hours. Yes, go ahead.
I just wonder if there's an age limit on the clinical trials for FSGS.
No, I think like 90 years or something like that. So yeah, usually we've never had anybody that we didn't take because of their age.
Okay, because my daughter just got diagnosed and she's like 9. So.
Yeah, and there are a couple of trials, as Josh mentioned last night, that's a focus of NephCure. We're working to hopefully generate more options for pediatric patients in trials, but there are a couple, and there's a couple coming. So we have a clinical trial finder tool on our website that you can type in her information and it should pop out what she possibly would qualify for.
Okay, that was my question. Thank you.
Boehringer Ingelheim and Walden both have trials that will probably, your child will be eligible. They're going through very interesting mechanisms. One blocks something called TRPC6 and another one blocks SUPAR. So for sure, she should enroll in a trial. There is some really nice, we now understand some of the pathogenesis of FSGS better, and we are developing good targets that need validation and show that it works in humans. So if you all have FSGS or family members with FSGS, 100% they should be in a clinical trial. We don't know very well how to treat FSGS other than steroids and maybe calcineurin inhibitors. And so there are now new medicines working on better pathways, far less risky, fewer side effects.
You have a question up here, Bert.
I mentioned something about genetic testing, and if you have FSGS, how important is it to have the results of the genetic testing to enter into clinical trials or for that difference in outcomes?
Most clinical trials don't need genetic testing. I think genetic testing is useful I think most patients with FSGS should get genetic testing to make sure they don't have like very well-known mutations, either portosin mutation or nephrin mutation or alpha-actinin 4 mutation. Because as we gather this kind of information, somebody will start developing a drug specifically for that disease, that mutation causing the disease. So FSGS is not a very specific disease. It's a basket term for people that have damaged kidneys that have scars all over it. What causes the FSGS could be a mutation in one of the genes, like the ApoL1 mutation or the nephrin or portosin mutations. Sometimes we saw it spike after COVID infections. Sometimes certain drugs like heroin can cause you to get FSGS. So FSGS is a convenient pathologic term that tells you that the kidney is scarred. What needs to happen when a diagnosis of FSGS is made is the doctor has to go back and think about why does this person have FSGS? Is it genetic? Is it because there is some circulating factor in their blood? Is it maybe they had reflux as a child or they were a premature baby or just bad luck? The default answer is bad luck, but there are many other things that we know that can cause it, so it's probably worth investigating so we can then develop better treatments. And the best answer to that is the ApoL1 FSGS, that a lot of African American patients develop FSGS and it was thought for decades just bad luck. Once they discovered something called the ApoL1 gene mutation, now there is going to be a drug for it, probably in the next year or two.
My daughter is 8 and she was diagnosed with FSGS at 3. She had genetic testing done in 2019, but with the advancements in like scientific technology and everything, they didn't see anything in her genetic testing at that time. Do you think with everything, the advancements, we should get genetic testing done again and see? Because at that time they didn't see anything, but
Which company did the test?
we did it in Kansas City, so I don't remember.
I think, if you don't mind, I'll take this one. I think you'll hear from Dr. Matt Sampson later today, and there's an actual breakout for pediatric genetics. There's also some studies that we could talk about enrolling her in, so that as they continue to develop or find new genes, then they would contact you if one came up that your daughter may have.
Thank you.
Yeah. All right. We'll do one more question. Ellie?
So I just wanted to kind of bounce on what she said about genetic testing. I have FSGS and for many years, and I have been fighting with my doctors and trying to figure out why my blood testing was always out of whack. And so I went to my nephrologist, who then sent me to an oncologist and said, hey, let's get genetic testing done. Let's see what's going on. And so I recommend everybody, if you have a chance to do genetic testing, do it, because first, turns out that I was born with a defect with my MCH. And so between the kidney disease and that defect, that's what always has my blood work always coming out all differently. But then on top of that, I came out positive with a variant, which is ATM, which now puts me at a risk of getting breast cancer. So all these things that that sometimes we leave on the back end burner or say, well, should I or shouldn't I? Get it done, because it's so important to know what's happening, because it doesn't only affect you, but it affects your children, your children's children, and it is really important to get all these testing and go to the clinical trials as often as you can.
No, I have a professional colleague, a friend of mine that came to my clinic because he had proteinuria, and we ran genetic testing on him. It turns out that he had a syndrome that increases risk of kidney cancer. And so I told him, you have to get your kids tested because it's an autosomal dominant disease. And one of his children were tested positive, and when they scanned him, he actually had a tumor in his kidney. So he underwent surgery to remove the tumor, which if they had left, so.
I always ask, we're supposed to look at that, did I get him up? And so it turned out that 5 years ago, I went back home because my mom was not feeling well and ended in the hospital. So I asked for all her medical records. And when I started to read it, I went up to my mom and I said, Mom, you have CKD stage 3. Like, you're the one who gave me my kidney disease. And so the part that made me upset was that the doctor never told her, so she never knew. And the excuse was, well, they're old and we don't want to stress them with all kinds of things. And I was livid. But because of that, I said, you're going to do an ultrasound, you're going to do all these kinds of testings, and bam, solid mass cancer on her right kidney, which they were able to thankfully take it out, and it didn't spread.
Thank God.
But if you weren't an advocate and you're not on top of it, who knows how it would have turned out. So yeah.
All right,
it's
one more.
Yeah, I just have a comment about genetic testing in the context of being an activated patient, right? Because actually, to me, seems that genetic testing is something that is the real truth, right? When you do the genetic testing, that's it. It's the result, and nobody can dispute that, right? Well, I had 2 genetic testing done from one of the major kind of clinic in the United States and actually in the world. And I have two different clinic did the 2 different genetic tests and to 2 different basically lab that do these genetic tests, and they contradict each other. So one genetic test say something, and the other one say completely different, right? And I asked the doctor, and now I'm still like, as an activated patient, I'm trying to understand. I asked, so what's going on? And the doctor told me, well, genetic testing is an interpretation. So I just want to make this comment, and I hope that I will clarify during these 2 days, speaking with expert here, why there is this kind of controversy in genetic testing. This is just my comment.
So he is my patient, so I guess he's trying to keep me straight and honest.
Just calling you out real quick.
He's just
before you
calling
get
me
off
out. No.
stage.
So I agree. So it is open to it. So how do you actually know that a particular gene causes, a gene mutation causes a particular disease? Right? Let's think about this. You take all those people that have a specific disease and run their genetic analysis, look at their DNA, and see if there are any variations from what is defined as the standard set. And so is that variation, the number, the letter sequence, if it is represented more commonly in diseased patients than in non-diseased patients, then you make the presumption that this is the cause. And then you find out if there is a pathway. So the more people get genetic testing, the more information the databases process. So then we can have more fidelity or confidence that a specific mutation causes a specific disease. So that's why I exhort everybody that has a disease that is not very clear to go get genetic testing, because then you can make it better for other people to figure out if this gene difference caused this specific disease. So we only know what we know. We don't know what we don't know. And as we gather more information, we can be better at it.
All right. Well, I just wanted to let you know that as we move through about our days, one of the biggest things that we hear from patients is they want to hear more patient stories. They want to meet more people. So you'll see on your tables patient stories who have generously shared their story. But also we have what we call MCs, patients who have volunteered to just share a little bit about their story as they introduce our next session or provide an outro. So with that, I want to thank Dr. Mandayam.